Good afternoon. I'm Barry Kramer, the Associate Director for Disease Prevention at the National Institutes of Health. I'm very pleased to be here this afternoon to provide opening remarks for the 16th year of the NIH Gordon Lecture. This award is given each year to a scientist who has made major research contributions in the field of epidemiology or clinical trials. It is presented by the National Institutes of Health based upon recommendations from senior epidemiologists at the NIH. The Gordon Lecture was established in 1995 in tribute to Dr. Robert Gordon for his dedication to the field of epidemiology and his distinguished service to the National Institutes of Health. During more than 30 years of service to the NIH, he served in numerous senior leadership positions, including Director of the Clinical Center and ultimately as Special Assistant to the NIH Director. His breadth of knowledge and experience in the clinical sciences led him to become Chief Advisor for Clinical Practice and Research to two NIH directors. For the last 10 years of his life, Dr. Gordon made important contributions to inter-institute policy and management issues regarding epidemiology, clinical trials, and the health effects of environmental hazards. This award lecture is named in his honor in memory of his distinguished career and unique scientific contributions. This year's Gordon Lecture Award recipient is Dr. Julie Buring. She is currently Professor of Medicine at Harvard Medical School and Brigham and Williams Hospital and Professor of Epidemiology at the Harvard School of Public Health. Dr. Buring is an internationally recognized leader in the study of cardiovascular disease and cancer. Her seminal work in cardiovascular disease in women has made broad, immeasurable contributions to the field of women's health. For many years, the study of primary and secondary prevention of cardiovascular disease was conducted nearly exclusively in men. The groundbreaking women's health study, a randomized controlled trial of low-dose aspirin and vitamin E for the prevention of cardiovascular disease as well as cancer among 40,000 female health professionals, was conducted under Dr. Buring's leadership. As a result, important differences in aspirin treatment among women versus men were recognized for the first time. Important public health recommendations came from that study. Dr. Buring's work also quantitated clinically important adverse effects of aspirin treatment that are important to informed decision-making by women and their physicians. A primary focus of Dr. Buring's research has been on the analytic and clinical epidemiology of chronic diseases. She has been an intellectual leader in the design, conduct, analysis, and interpretation of several landmark, large-scale randomized clinical trials and observational cohorts. She is still the principal investigator of the Women's Health Study, which continues to follow participants observationally. She is co-investigator of the Physicians' Health Study 2, which evaluated the preventive effects of vitamin E, vitamin C, and beta-carotene on cardiovascular disease, cancer, vision, and cognitive function among 15,000 male physicians. She currently is co-investigator of the newly funded randomized trial of vitamin E and fish oil for the primary prevention of cardiovascular disease and cancer, known as VITAL, that will be initiated among 20,000 men and women this year. Dr. Buring has published extensively and has served as a reviewer or editor on numerous scientific peer-reviewed journals. She believes strongly in giving back to the scientific enterprise by serving as an active member of professional societies and giving of her time to serve on NIH study sections, advisory committees, and data safety monitoring boards. In fact, Dr. Buring is the chair of the National Cancer Institute's Prostate, Lung, Colorectal, and Ovarian Cancer Screening Study, or the PLCO study, and it has been my pleasure as an investigator of the PLCO to work with her for more than a decade. I'm proud to claim Julie as a colleague and as a friend. Dr. Buring has received numerous awards and honors, most recently the Roger L. Nichols Excellence in Teaching Award from the Harvard School of Public Health in 2007 and the John Snow Award from the American Public Health Association in 2008. Among her students and peers, Dr. Buring is treasured as a skilled mentor to many young, promising investigators and has been honored with numerous awards for teaching over the years. She is actively involved in the teaching and training of students and fellows in epidemiology and is co-director of an NIH T32 training grant in the epidemiology of cardiovascular disease. Her dedication and enthusiasm are an inspiration to many doctoral students who have gone on to careers in both research and clinical medicine. The topic of this afternoon's presentation is of great interest to the research community. It's also a source of confusion and sometimes frustration to policymakers, the general public, and journalists when they're faced with differing results from what appear to be similar studies. Today's presentation will accentuate the point that we must look at the totality of evidence in order to understand where we are in the knowledge of a particular research question. The talk will explore the strengths and limitations inherent in virtually every study design. Exploration of discrepant results can lead to improved study designs and a more informed analysis of study results. I'm delighted to introduce Dr. Julie Buring as this year's recipient of the NIH Gordon Lecture Award. Her presentation is entitled, "What Do We Do When Studies Disagree?" She'll speak for about 40 minutes, and then the audience will have an opportunity to ask her questions for another 15 minutes. There'll also be a reception, which in this year is in the NIH library around the corner, after the lecture to allow more discussion with her and one-on-one interactions. Please join me in giving Dr. Buring a very warm welcome. Julie.
Good afternoon, everyone. Dr. Kramer, thank you so much for that very kind introduction. It's really very nice to be here. It's very much a feeling of coming home when I'm back here. I'm honored to have gotten this award, to be giving the Robert S. Gordon Jr. Lecture in Epidemiology today. But the reason it means so much is because it's coming from my community at the NIH. And I've been very fortunate to be able to work with many of you through my Data Safety and Monitoring Board activities, or by my study section activities, or through workshops. And as a result, there are so many of you here who truly are my colleagues and my friends, and it's just very nice that I would be receiving this and be speaking with you today. The other thing that was nice when I started to pull together my talk was that it gave me the opportunity to just think a little bit. I was thinking about discrepant results, but I was trying to put it in a broader context. And the context I was thinking about is sort of what I have seen change over these last few years. And then I could think about how the results were going to fit into that. And there were sort of two sections of changes that I thought that I had seen. And the first one is that there really has been a major change in the public's understanding about the importance of epidemiology studies, and that they're actually seeking the results of epidemiologic studies. Don't forget, I came from a time that when I first got my degree, I never told anybody that I was an epidemiologist because nobody actually knew what it was that I did. And they would be very proud if they thought that meant I was a skin doctor of some kind. And after we explained what epidemiology was, I just said I was in medical research. But that's not a problem anymore. People are much more aware of it. People are much more appreciative of it. And as a corollary of it, there's an increasing focus on everybody on the idea of prevention of disease and how epidemiologic studies, clinical trials can add to that information. And why has that happened? Well, in part because this country is aging, and that's making a difference. And in particular, if you just look at the executive summary of the United Nations report on world population aging, there's 4 major findings that are directly related to it. The population aging in the world is unprecedented. By 2050, the number of older people in the world will exceed the number of the young for the first time in history. The population aging is pervasive. It's all over the world we're dealing with this. It's profound. It's having major consequences and implications for all facets of human life, economic, social, political, and it's enduring. It's not going away at all. And so the change in focus has been that not only do we want to live longer, do we want to live at all and then live longer, but we want to do it in a good way. We want to reduce disability. We want to improve our quality of life. We want to do what's called successful aging. So not just getting older and not dying, but doing it successfully. And we want our morbidity to be compressed, meaning that we are healthy, living the life that we want to for a very long period of time, and then there's a very short transition phase to having morbid events and then mortal events. So prevention is something that we believe is very important, or people believe is very important, not just treatment. And it's not just the United Nations that's worrying about it. That quote that I think most of us feel as we get older was by Eubie Blake, who is a jazz pianist, who said, "If I had known I was going to live this long, I would have taken better care of myself." And the point that we try to get across to everybody is that it doesn't matter when you start. Yes, it would have been better if we did everything well when we were in our teens or in our early adulthood, but that even if we start in middle age or adult or older age, what we do makes a tremendous difference to what happens to us after that. So if we care about living well, aging well, and if prevention is important to us, then the next things are actually correlates of it, is that there's been a substantial increase in the complexity of the interpretation of a study's findings. We're not talking about magic bullets anymore. We're beyond the penicillin type era. We're really at the point where we can come up with things, we are looking for things that are small effects statistically, but very meaningful to us from a clinical or a public health standpoint. But if they're small, then it's like finding a needle in a haystack to find them definitively, to demonstrate them definitively. And so what we have to do is deal with that complexity, both in terms of our understanding the implications of it for the results of the studies we do and we read, and also in terms of communicating our study findings, so that we give accurate messages and we do better studies. And why is that so important? Because we truly have sort of a public relations crisis out there in terms of being an epidemiologist. I'm sure all of you have seen this slide, but I really remember it and I keep it because it reminds me of what kind of questions people ask me. As much as I could go on forever about the relative merits of different kinds of bias and what it means in terms of the validity of certain kind of results, you know that the bottom line questions that people want to know is, just tell me, is it margarine or is it butter that I'm supposed to be eating? Or the number one question that I get asked is, I know exercise is good for me, what is the minimum amount of exercise that I need to do to be able to have a benefit on cardiovascular disease and cancer? And then when someone sees something they don't like, how many times have we said, well, just let the scientists keep on going. They'll change their mind tomorrow, which is sort of the underlying of this cartoon. But it isn't just the public that gets a little bit concerned about not understanding what's happening and confused. It's the scientists too, the ones who actually should be able to read the literature. And there was a poll that I thought was very telling about 2,000 attendees at a primary care medicine convention, workshop, CME kind of thing. Half of them were physicians, and they just asked them two questions prior to the lectures. In particular, since the publication of the Women's Health Initiative, my understanding of the risks and benefits of hormone replacement therapy is, and 48% of them said much less clear than it was before. And since the publication of the findings, my comfort with counseling patients about hormones and menopause is much lower, 54%. And so this isn't a matter of not being trained, it's a matter of the complexity of the kind of data that we see. And then finally, a little picture that I saw as I made my own personal change from being a classically trained epidemiologist to having to integrate genetics into my studies, biomarkers into my studies. There was a wonderful Christian Science Monitor cartoon of someone in the front of a roller coaster on the DNA helix with a look on his face that is exactly how I felt when I realized that I had to figure out how genetics would go into and complement the kind of studies that I was doing, and how was I going to analyze it, and how was I going to interpret it. So why is this so hard? It's hard because no one study can definitively answer a research question. So we know that a research question can be evaluated by a number of different epidemiologic strategies, that we all pick them on the basis of the question in terms of logistics, in terms of our resources, in terms of our money. And what we feel but need to remember explicitly is assessing where we are in our knowledge about any question is going to require looking not at one study, but at a totality of evidence. And that totality of evidence is going to include the basic research, whether it be animals, whether it be genetics, whether it be molecular biology, that gives us the underpinnings for the mechanism by which our intervention or our risk factor or our exposure may be working. And then the epidemiologic studies, which are our direct evidence in humans. And they will come in many varieties. And the two biggest ones that we'll talk about today are the observational studies, where we simply watch what people choose to do, and the intervention studies, the randomized clinical trials, where we try to make it as close to that basic research as we can by trying to control or intervene on the environment. Well, observational studies, it's often said that there's a hierarchy to studies, and the randomized clinical trials are sort of the gold standard of the research. I would say that more in general, I think every study has its niche. And for every niche, every question that we're trying to answer, there is a study that is sort of the, not necessarily the very best you can do, but the appropriate one to start with. So when I think about observational studies, there's no question that they have advantages in terms of being simpler, being less expensive than doing a randomized trials, but that's more of a logistics issue, not a science issue. When I want to go to the observational studies, it's when I'm looking at the big effects, which usually is not what I do. When the required duration of exposure is long, and that's a very important one because trials are usually on the order of 3 to 5 years. And when something may take longer to show us an effect on a chronic condition, observational studies really can give us information that other kind of designs may not be able to. Sometimes it's the only way to go, meaning that it's not feasible or ethical to do a trial, and we'll talk about that in a second. It's always going to be useful. It's always going to be extremely useful for us to go the next step and to design a new trial, because through our meta-analyses and through our systematic reviews, it is the way to look at these observational studies and get a sense of where we are in our knowledge as of right now. What order of magnitude effect are we talking about? And then the most important thing is they work. There are a tremendous number of risk factors and preconditions to getting an outcome that we have learned through our observational studies, of course starting with cigarette smoking, since you can't randomize something that's harmful. So when we look at it, we may say that we want to go to our next step to trials, but we must never underestimate how much observational studies do for us. But there are limitations of observational studies that are inherent, meaning it isn't that if you did a better study, trained better, learned under a master of doing observational studies, they would be different. This is inherent in the design. And in particular, it's because the exposure is self-selected. And anytime people select an exposure, they select more than that. There is a whole host of exposures or lifestyles that go along with eating a certain way, acting a certain way, getting a certain kind of drug. And so there is a risk of selection bias or differences in outcomes that are not due to the treatment itself, but to these other factors that are related to the exposure. And if we understood them well, we would actually be in better shape with respect to observational studies. But we know so little about so many diseases in terms of risk factors. So the adjustment may not be adequate for these confounders because we don't exactly know what the risk factors are, or in fact, if we don't know about them, we can't even measure them adequately to be able to do this. So really what observational studies can do is give us the best, albeit a little vague, answer to real life questions, while we always know we're going to be saddled with concerns and residual doubts about confounding. So the randomized clinical trial, how does that complement observational studies? Well, yes, it's more costly. Yes, it's more logistically difficult. Yes, there's issues of ethics and feasibility that you won't see in an observational study. We know you can't randomize harm. We know that people have to be willing to be randomized in a study rather than just being followed. But if we can do them, if they are well designed and conducted, their niche is that because they are minimizing bias and confounding because of the way they are designed, the randomized, double-blind, placebo-controlled, intention to treat analysis, those aren't ivory tower words. They are all to minimize bias and confounding. And because of that, they can accomplish in their design, if they're well designed and conducted, what the observational studies strive to do and have difficulty doing. They can detect statistically small to moderate effects, which are so important to us, but so hard to definitively evaluate because of their design. Now, so if we said that observational studies give us this best vague answer to real-life questions, trials will give us a precise answer by minimizing confounding, but to very specific questions which may not in fact reflect real life. So how do those go together? Well, it has been shown that in a majority of situations, or many situations that can be found, that the trials and the observational studies give us about the same order of magnitude. And there was an article in the New England Journal that documented that. There was a commentary on afterward that said we found little evidence that estimates of treatment effects are consistently larger or qualitatively different than those that you get in the trials. But the fact remains there are situations where, in fact, they are different. And it's when they are different that we learn so much about sharpening our skills in doing analysis and absolutely sharpening our skills about designing better studies for the future. And so what do we do? What could it be when they're different? Well, it could be that something went wrong with the observational study. It could be that something went wrong design-wise with the trial. It could be that both of them were not designed well and they just came to different answers. Or it actually could be that both of them did answer the question that they were given to answer, but they're answering different questions. So what have we learned from that that will allow us to do better in the future? So I want to use very quickly 4 examples that I've sort of lived through over this last period of time. Hormone therapy, risks and benefits from the Women's Health Initiative, aspirin and cardiovascular disease in men versus women in the Women's Health Study, beta-carotene and lung cancer, or a nutrient, so beta-carotene and lung cancer, and then vitamin E and cardiovascular disease. And I'm going to touch on these not so we go over the findings, because you know these examples, but we go over what then the message was that needed to be looked at to figure out what happened. The Women's Health Initiative, we all know very well, observational study plus a trial, and part of the trial was to look at hormone replacement therapy on heart disease, osteoporosis, and breast cancer. Women who did not have a uterus were given conjugated estrogen plus progesterone versus placebo, as opposed to women who had had a hysterectomy. And the point was to look at whether the estrogen plus progestin decreased heart disease and osteoporosis-related fractures, increased risk of breast cancer, so that basically how did it come out on a balance of risks and benefits on overall health. Now remember where we started when we started the trial. The trial had to be in a context, a totality of evidence. And the totality of evidence was about as consistent on observational studies as we could see. That based on more than 40 observational studies, if you looked at the summary relative risk, the summary relative risk was a 36% reduction in risk of coronary heart disease among women who had ever used hormone replacement therapy, and about a 50% reduction among those who were never users. And they were consistent whether you did population-based cohorts, cross-sectional, case control studies. It didn't matter. You were seeing the same kind of finding. And many people felt that it was so consistent that it was actually unethical to give a woman placebo because she would be denied the benefits of hormones. But what swayed the thinking to allowing enough investigators to do the trial is confounding. That women who took hormones for an extended period of time were going to be different than women who didn't take hormones for other reasons that could in themselves affect the outcome under study. if they were doing this to prevent their risk or lower their risk of heart disease, they were probably leaner. They were probably not smoking as much. They were more physically active. They saw their doctors more regularly. They were more educated. They were sort of doing everything that they could, and this was one of their weapons they were using to reduce risk of heart disease. But all these other factors could in themselves affect the risk of heart disease that we were looking at. So the only way to get around it, to get those confounders evenly divided, was to do a trial, randomly assign them to hormone use or placebo, follow them up. And if we still saw a difference, then it was likely to be due to the hormone and not to the differences among these other factors. Well, the Data and Safety Monitoring Board watched the trial as it should, and after 5 years of data, they decided that the estrogen and progestin group needed to stop their study pills because of unexpected findings. Everything we're going to talk about is always unexpected. This is not anything that anybody thought was going to happen, yet we needed to examine it and learn from it. That the balance of harm and benefit was not at all what we thought it was going to be. The lipids were being benefited just like they should, lowering total cholesterol, lowering LDL, raising HDL, but the clinical endpoints weren't being benefited by the taking of hormones. And in effect, what the findings were is completely unexpectedly, there was an increased risk of coronary heart disease, increased risk of stroke, of pulmonary embolism, of breast cancer, decrease in hip fracture, decrease in colorectal cancer. So the equipoise that the trial had started with was no longer present, and the DSMB acted on that. They also, though, calculated just because you have a relative increase, what does that do for your absolute risk? So they worked out for 10,000 person years on the drug that there would be 19 additional adverse events per 10,000 person years. But the important thing is how low that was. So even though it was more in the active group, it had increased it by 50% or 100%, the absolute risk was low, and that's very important. So first we had to give a message to people. And the message is that estrogen plus progestin shouldn't be initiated or continued if you're doing it just for the primary prevention of coronary heart disease. And if you're doing it for the primary prevention of osteoporosis, then given the other risks, it would be better to weigh them against the benefits and see if there's other available agents. And given the low absolute risk and the relationship of the risk to time after menopause, it can still have a clinical role for people who are taking them for menopausal symptoms, using the lowest effective dose for the shortest period of time. So that was sort of dealing with the participants and the public. But what about us? What was the message to researchers? Well, the message to researchers was basically, what happened here? How is it possible that not only did it not benefit heart disease, but it went in the other direction? So let's look at it a little more closely and go through the steps that were examined. The first is that they looked at all the outcomes for this study: CHD, stroke, pulmonary embolism, hip fractures, breast cancer, and colorectal cancer. And if you notice, the observational versus the trial were right in line for absolutely everything except coronary heart disease. So now the question is not how is it possible that the observational study showed a benefit and we actually showed harm, but it was for coronary heart disease that happened and not for something else. That's sort of like if you think of NCIS or Law and Order or something like that. We're getting our little clues to go a little bit farther and try to figure out what the problem really is. Well, it could, of course, be methodologic differences. It could be the confounding that was uncontrolled in the observational study. It could be that the compliers are different than non-compliers. I understand all this. And all of that challenged us to develop better analytic methods to try to be looking at a subgroup of the trial, at a subgroup of the observational study that was most alike in terms of these factors. It also raised a caveat that I don't think any of us had actually thought of before, that if you're in an observational study where you send out a questionnaire every 2 years, it is very possible for an early effect that your baseline, you didn't use the drug, you didn't use replacement hormones, You then started to take it, you had a problem, you came off of it, and by the 2 years when you next got a questionnaire, you were a non-user again. So you come up as a non-user at baseline, non-user at 2 years, and what you miss completely is, in fact, you did take the drug in the middle, something happened associated with the taking of the drug, and that was not going to be picked up by this kind of study. That was a real learning experience for a lot of people with observational studies. But the real difference was biology. So if I'm trying to repeat what happened in an observational study, how close was I to the observational study? And in part it was because the characteristics were different. These were older women. They were 63, 10 years after menopause, as opposed to the observational studies that were right at menopause. They didn't have vasomotor symptoms in the WHI, but they did in the observational study. They were heavier. Their endogenous hormones were different, is what we're trying to say, rather than just exogenous hormones. So that maybe, and this is when we then go back to the biologists. Now we're back to the basic researchers. We come from epidemiology back to the basic sciences. That maybe, in fact, the progression of cardiovascular disease, as it goes along over time, goes through a period right after menopause, whereas a favorable lipid and endothelial effects of estrogen predominate, and you'll have a favorable influence of initiating exogenous estrogens. But as you continue on over time, you go to another period in a woman's life where there are prothrombotic and pro-inflammatory effects of estrogen predominating, and we could have an adverse effect. And this was something, this subtlety was something that was not known before, but was known from seeing the data and taking it back to the basic scientists and saying, help us work out what could possibly be happening. So the results were sure. The methodologic limitations led to an overestimate of the benefits of hormones, but we can work on that. We can try to control better. The elevation of risk in coronary heart disease might never have been seen otherwise. The biological difference ones make it that these are two questions that are not directly comparable. They're really just addressing different questions. It led us, or the community, to better analytic approaches of comparing data from the two kinds of studies, and it also led to a subsequent study to evaluate, which was now an unanswered question, which is what happens if you start women on estrogen within 3 years of their last menstrual period. Maybe that is closer to the observational study, and that is a trial called KEEPS, which is currently ongoing. So let's think about another kind of example, women's health study. Randomized double-blind placebo-controlled trial of low-dose aspirin and vitamin E in the prevention of cardiovascular disease and cancer, conducted among 39,876 female health professionals, funded by National Cancer Institute, National Heart, Lung, and Blood Institute, and the pills were provided by industry. The trial is now over. We're following the women observationally. So this was our randomization. A quarter of them got aspirin, a quarter of them got vitamin E, a quarter of them got both, a quarter of them got neither. 2 by 2 factorial design. When we started aspirin, I would have placed money on knowing the results of this trial. We know in secondary prevention, among those who have had evidence of clinical evidence of cardiovascular disease, aspirin reduces your risk of having a second event or dying from cardiovascular disease in both men and women. And we know if you're in the middle of having an acute coronary event, that if you give someone an aspirin crushed or chewed, you will lower their risk of having a second event, dying from that event during the high-risk period in both men and women. Primary prevention, healthy people, would it help us to take an aspirin every day to prevent an event that may or may not occur sometime in the future? Well, we knew in men that it reduced the risk of a first heart attack, but there weren't much data on women. And we felt that if you're going to make a recommendation for half the population, you should have some data on that part of the population. But I really would have put money down that you would have seen a benefit on myocardial infarction. So the recommendations from AHA, from the U.S. Preventive Services Task Force, really were for men and women, but the direct evidence was sparse, and that was the reason for starting the aspirin and cardiovascular component. I just want to show you a couple pictures just for a second. You know, I'm talking a lot about doing these trials like, you know, you just go out and you get 40,000 women and you do them. Women were not used to being in clinical trials of heart disease. Heart disease trials had traditionally been of middle-aged men because that was where the highest incidence of heart disease was. So we really had to do a lot of education to teach them about randomization, about not knowing what pill you were on, aspirin or placebo, vitamin E or not, and getting them to understand that we could design the nicest trial and be fortunate enough to be funded. But if our participants were taking their drugs and allowing us to follow them over time, we were never going to be able to answer the question. So the participants helped us by actually, when we'd get letters that say, I don't know how to take my pills, I never can seem to remember that, they would actually send us pictures of themselves saying, you know, if I can do it, you can do it. I can go all over the globe and I can take my calendar pack with my pills in it and I can be part of science while enjoying my life. So I just wanted to show you, these were the Women's Health Study calendar packs going to the Leaning Tower of Pisa and the Great Wall of China and Antarctica, and my personal favorite, Miss Senior Florida, who's on her float with her calendar pack. All right. So what do you do then when you really did a very tight study with wonderful participants, and I would love to give them just a really crisp little soundbite message about the role of aspirin. But instead, the results were not compatible with what we had seen previously. In particular, there was absolutely positively no benefit on myocardial infarction whatsoever. Not from the beginning, not to the end. No matter how we looked at it, there was no benefit. But there was a very clear benefit on stroke. In particular, ischemic stroke, and of course there's a small increase in hemorrhagic stroke that goes along with the taking of aspirin. So our message to men and women had to be different. It was, for both of you, there's going to be a reduction in risk of cardiovascular disease, but the type of cardiovascular disease will depend on your gender. And you will have a reduction in risk on the one you are most likely to get. So the number one type of cardiovascular disease in a man is a myocardial infarction, and in a woman it's a stroke, and for each of those we saw a benefit. But there wasn't a clear thing. It was different than what we had anticipated. Again, unexpected. And why was it? This is now to the researchers. The question I was asked most often was, go through the reasons this could be happening. Could it be you didn't give enough of a dose? 100 milligrams every other day wasn't enough. But I knew, I did it beforehand, gave 100 milligrams every other day. It did what it was supposed to do. It lowered the thromboxane levels just like it was supposed to do, the prostacyclin levels, and it happened in both men and women. So then they said, alternate day. Well, we did that exact dose and regimen, and we showed a reduction in stroke. So it obviously was working, and it also increased the risk of a hemorrhage, which again is exactly what the side effects of aspirin are supposed to be. So it was coming out with the adverse effects. It was coming out with a beneficial effect on stroke. It wasn't due to compliance. It wasn't due to a loss over time, because we saw it from the very beginning. So it left us with a path that we had to follow, which is figure out if, in fact, on this, there is a difference between the genders. And this, again, had to go back to the basic sciences and say, work with us here. How could it happen, not happen on secondary prevention, not happen in acute coronary disease, but happen in primary prevention? What is going on? And then what we saw that we had to add into the mix is that if you just looked at older women, they in fact looked exactly like men. So if you did it over the age of 65, here was your benefit on stroke, and here was your benefit on myocardial infarction. But I still had to worry about risks and benefits, because these 44 fewer events caused 16 additional hemorrhages. So is it enough to be able to recommend it? The AHA guidelines said anchor to 65. Do something different if you're under or lower 65. I don't agree with that, because I never set 65 as my cutoff in advance. I think 65 is we finally just had enough events, enough myocardial infarctions, since stroke occurs more frequently at younger ages. We finally had enough heart attacks for us to be able to look at that definitively. So what comes from this when you kind of see these differences? This is never going to be completely resolved, meaning that primary prevention is just never going to be the same as secondary prevention. It's always going to be an individual clinical decision where we sit with the man and we sit with the woman and we look at his risk factors for heart disease, and we look at her risk factors for stroke, and we look at both of their risk factors for having an adverse event from the taking of aspirin, and we figure out how that risk to benefit analysis goes, because there are discrepant findings between the two. And I never started this study thinking that I would be doing it to find something different. But what it does underscore is the importance in looking at subgroups, if they're large enough, important enough to us, to make sure that there are not differences between the groups. Now, beta carotene in one slide, I think we remember this one. This was sort of the beginning of what I thought it was my time when I felt like that there wasn't a Santa Claus or a tooth fairy anymore. Things weren't going the way that they were supposed to. We knew that people who ate their 5 servings, 7 servings of fruits and vegetables had a lower risk of cancer, as well as cardiovascular disease. We knew a mechanism. They were rich in beta carotene, those fruits and vegetables. We understood that beta carotene was an antioxidant. There was no suggestion of harm, either overall or in the subgroups of smokers, non-smokers, or anybody else. So trials began completely appropriately. But they showed no benefit of beta carotene on cancer prevention in well-nourished populations. And again, unexpectedly, they saw harm that had not been seen in the observational studies. Both CARROT and ATBC saw harm among lung cancer incidence and mortality among smokers. The Physicians' Health Study didn't see that, but 2 studies did. And there was no idea at that time of a mechanism by which beta carotene could be increasing risk in smokers. And so that went back to the basic researchers. We've learned a lot since then. That raised questions about the role of specific nutrients in cancer prevention, nutrients versus food, and trying to see whether we could look closer at the observational studies to try to see a better relationship. Maybe food wasn't beta carotene. Maybe that was the wrong nutrient to have picked. So then vitamin E became in vogue. And the advantage of vitamin E was because most of the vitamin E that was shown to be beneficial in the observational studies was supplement level, not food. So it wasn't a matter of looking at the food and saying, well, it also seems to have a lot of vitamin E, let's look at that. You were really in supplement level, and so it seemed to be more direct. But again, those who had vitamin E supplements might be systematically different from those who didn't. How do you know it was those who were eating a high amount of vitamin E that it was the vitamin E and not something else? So again, a very logical progression from the observational studies to the trials. And the trials that had been done were secondary prevention, not long enough, not primary prevention, meaning that they were very informative for what they were looking at, but we still didn't know if there might be some effect with longer durations among healthier people. So we did the Women's Health Study component to look at it. And if you ever want to just see a really flat results, no effects, this is one of them. The combined endpoint of MI, stroke, and cardiovascular mortality, no effect. Stroke, no effect. Myocardial infarction, no effect. Reduction in risk of cardiovascular death, slight amount, and basically no effect on all-cause mortality. Now, taking that all together, this really was a classic example of what was promising in the observational studies not holding up through the trials. It wasn't that it reversed direction, it just didn't hold up. And for me, the closest when I do my analyses is trying to get a better sense when you control for confounding or match the 2 groups analytically. Can you get them closer together? And for us, we really can't do it. So I don't know what the big confounder is, but I do know that it didn't hold up in this kind of study, and the data do not support the use of vitamin E supplements for the prevention of cardiovascular disease. So back to what I said at the beginning. What happens when they are just discrepant? The possible implications we said is that one is wrong, 2 are wrong, or neither are wrong. But I think another way to look at it is the following, that the lessons I have learned is that sometimes when there's discrepancies between observational studies and trials, or become one type of trial and another, or one subgroup and another, there's nothing wrong at all. That is exactly our system working, our knowledge proceeding, going from a promising hypothesis that has a limitation into how far it can be taken, especially with the uncontrolled confounding, passing the baton on to a clinical trial and say, you try to get it tighter, you try to get the bias and confounding out, and let's see what we have. It was promising, it was unproven, and it didn't hold up when the trials were done. And that's okay. All we want is to definitively answer the question, either to clearly demonstrate a benefit or clearly demonstrate there's no benefit, so that we can go on and use our scarce resources to look at something else that's more promising, our next hypothesis. Sometimes looks like there's apparent discrepancies that aren't necessarily contradictory. You're just looking at a different question. And that one, sometimes you don't pick it up right away. I don't think anybody picked up that 10-year difference between when the observational studies, the women usually started their hormones, and when they started in the WHI, was going to make that important an impact on the interpretation of the findings. It sort of opened up a whole new world of thinking about what happens to a woman after the menopause. And the other thing that I've learned is how important it is to work as a team. That it's not me alone as an epidemiologist or a clinical trialist, but me working with basic scientists and then the clinical expertise, the epidemiologic expertise, and the trial expertise up front to design the study in a way that will maximize my getting a true answer to the question that I want to answer. You got to look at sources of error at every step, from a single observation to a randomized clinical trial. And when you are using the observational studies as the rationale for your trials, you have to understand how the design of the trial could differ from the environment of the observational study in ways that could affect the outcomes under study, whether it be patient characteristics, agent characteristics, the underlying biology. You got to think about it. That is the clearest message from what we lived through. And that this upfront consideration of differences really allows us for a more intelligent use of observational data in themselves and for designing trials. My bottom line is that you shouldn't be relying solely on trials nor solely on observational studies. You really need what both can give you. But data from those trials really are needed, especially in this era of emphasis on cost effectiveness, head-to-head comparisons. And working through these examples of discrepant results has greatly improved, I think, our entire field's thinking and our methods. It's just taken us up a notch in terms of being able to handle these kind of complicated situations. And then when the trial for vitamin D is starting, this month, where we're taking 20,000 men and women and giving them vitamin D or placebo, and then fish oil or placebo, I'm really very comfortable that I don't know whether there are going to be some issues at the end when we try to interpret, but we've really tried to use our observational studies in a way that directly led to what we're trying to test in the trial. And the last thing to end with, we said we care. We said people care. We said that prevention is important to us. We said it's getting more complex all the time. And we said how important it was to learn how to communicate our message. So the other thing that I've had to deal with that is really focuses how you write the paper, how you work with the media, and how you think about your totality of evidence is, to whom is my message? Or to whom is the message of a study that has just gotten published? Where are we in our knowledge? Is our message to other researchers? Is our message to healthcare providers? Is it ready to be going to the public? Is it ready to be going to regulatory agencies? And the type of data that we have with the limitations that come with it help us decide exactly how to craft the message that we need to do. And if I can just end with a couple cartoons. When we did the Physician's Health study in aspirin in men, the message at the end was always supposed to be that aspirin is a weapon that we have, along with everything else that we know about cardiovascular disease protection. It doesn't replace changing your diet, stopping smoking, controlling your blood pressure, controlling your cholesterol. It is a weapon that we can add to it. But we were very afraid that most people in the United States would rather pop a pill than change their lifestyle. So we're very afraid that the message would not come out the way we wanted. You can always tell how your message is doing by watching cartoons. So the first cartoon was a gentleman in front of the McDonald's counter saying, double cheeseburger, large fries, jumbo coffee, oh, and an aspirin. Got to take care of the ticker, you know. Holding a newspaper with a cigarette in his mouth, standing in front of the McDonald's counter. Well, that was absolutely the message that we did not want, that someone that's sort of primed for the outcome under study would not be clearly understanding how much difference they could make, forget aspirin, all the other risk factors that were sitting there in front of us that he needed to work on. So we worked with the media, and the next cartoon told us we had come a little bit farther, handing the bottle of aspirin, but saying, take an aspirin, but before you swallow it, take it for a 5-mile walk. So the beginning of getting a message that we wanted to communicate with all the complexity of when you take aspirin, individual clinical decision, weighing your risks, weighing your benefits, that we could at least get a message across about when to begin to think about taking aspirin. And then finally, when the advertisements change, you do know you're at a different level. Half-prin, 81 milligrams of aspirin. We're right there next to exercising, eating well, and not smoking. So finally, it was sort of being built with all the complexity and all the differences from what we thought in men and women. We got to the point where there was a message that could be applicable to anybody and would be understandable. So that's sort of what I've learned over the last period of time, and sometimes it's very frustrating. Everything is always unexpected. I would just like a study to come out expected, so it's just what I hope it will come out. But all I really want to do is answer a question definitively so we know what to do. And just to end, I said at the very beginning that more people were understanding epidemiology and what we are, what we do. Every once in a while, though, you read something that made me wonder what exactly people think we really do. There was something in Time magazine, William Hurt, actor, stage and screen. I just happen to really like his movies. And they asked him a question. They said, did you ever think about doing anything else? And the answer, I was looking up epidemiologists the other day, and I thought that might have been a great career. It involves so many different skills, and I love that. I have no idea what he thinks we do on a day-to-day basis, but I do know that over this period of time with all these changes, they may be hard, but it's definitely not boring, and it really gives us an opportunity to, as things change and it becomes more complex, to try to meet it and change our methods so we can give the best possible answer. Thank you very much.
Julie, that was great. The question I have is, if your vital study does not come out as you expect, have you collected ancillary data, biospecimens, whatever, so that you can go back and figure out why it didn't come out? And do you recommend that for various kinds of trials, prevention or treatment trials?
That's a very good question, and yes, it is really important to try to cover yourselves in terms of getting the information that you need to be able to separate out alternative explanations, either if something works or if something doesn't work. So what we have done for this trial, and we did it on our previous trials also, but this one is much more built in than it ever has been before. We're going to get a baseline blood specimen on absolutely the 20,000 in the study. We're going to have baseline levels of the fish oil and the vitamin D. We're going to be able to then look at how they change with the dosing of the agent that we're actually given. Does that matter your skin color? Because, for example, it is known that absorption of the sun, absorption of vitamin D are different among African Americans than it is in Caucasians. We'll be able to look at that. Whether the dosing results in different levels, blood levels, plasma levels, and are there any factors, genetic, biomarker, risk factors that would account for that? So at the end, we all know we do an intention to treat analysis. That's our primary analysis. But there's nothing wrong after that at trying to get into the subgroups and try to understand what could be happening. We're doing a number of ancillary studies in addition, where our trials tend to be done by mail. So it tries to keep the costs down. We send the pills. People send us back information on whether they've been diagnosed with the disease or not. We then go get a medical record. We're taking a subset of our participants and actually sending them into a CTSC unit, putting them into one of the units. We have one at Harvard. There are many in different institutions funded by the NIH, where you can actually go in and do deeper testing, imaging, biomarkers than you would be able to do on the entire population. Again, with them, we'll have a more direct correlation between what they're taking and actually the differences that we're seeing. So I'm hoping that we have now thought about enough of the possibilities of what could happen that we'll be able to look at all of them when the trial is over. Yes.
Julie, thank you very much. It was an excellent, very enjoyable talk. I have a question about the Women's Health Initiative and the biologic explanation of the heart disease issue. You pointed out in the Women's Health study that it was only women aged 65 and over who benefited from the aspirin because of the very low, you couldn't see it in the younger women because of the low event rate. In the Women's Health Initiative, I'm wondering if it was that you couldn't see the adverse effect of the hormones in that age group, in the younger age group, because of that low sample size. And I had thought that the Women's Health Initiative investigators had actually published a retrospective subset analysis of that younger age group in the trial and showed that indeed there was a small adverse effect, but it hadn't reached statistical significance because of the numbers.
You're absolutely right, and I didn't give all the data for that particular one, but you're absolutely right about them publishing on that, and in some ways those findings were the one that led or underscored the clinical recommendations about that age or time since menopause made a difference, which would support the relative safety of being able to use exogenous estrogens for short periods of time at the lower durations, and also gave the underscoring for doing another study. Okay. So I think, to be honest, I think they did the best that they could to try to pull apart what was there. But I don't think anybody really, I haven't talked to them lately, but I still feel that they think that there's unanswered questions, but there was evidence, especially in this particular analysis, which allowed them to make a clinical recommendation and then a study recommendation.
Okay, thanks.
I have a comment and a question. When I applied for graduate school, I told my brother that I was applying for epidemiology, and he too said, "What? You're going to study skin?" Well, thank you for such an inspiring talk. You mentioned earlier about genetics. Can you just comment on how you see that incorporating into randomized controlled trials in the future?
The genetic component of this is something that we've gotten into over this last period of time, I think, as everybody else has. And I think it's a very rich addition, but I don't know where it's going to take us yet. So for us, we have not found the sort of big differences that we had hoped when we looked at gene environment and gene environment, but we have it. And I think that as we are learning more, we've just very recently been able to do GWAS on everything in our women's health study, at least. We're going to be doing that in our vital trial also. And I can't tell you I know where it's going to go, but I do know very much that it's going to be considered to be a very hopefully rich part of the studies that we're doing.
We've come to the end of the hour, but please, maybe we'll take one last question, although we're going over time, and then we'll go into the library and you can ask Julie additional questions if you wish. Go ahead.
I have a general question, and that is about the future, in your opinion, of the randomized control trials. In your lecture, you have compared and contrasted observational studies versus randomized clinical trial. And it seems to me that it's a little bit like being between a rock and a hard place. And I'm not necessarily sharing this opinion, but some people say that, randomized clinical trial, they either ask the wrong question or they ask the right question at the wrong time. So along your lecture, you have alluded to the totality of knowledge, which is, as you know very well, a bias approach. And there are other options out there, adaptive design and so on and so forth. So my question is, if you had to design today the WHI study, would you do a randomized control trial, or would you use something, maybe a more modern, different approach?
Well, I wouldn't decide it without sitting around at a table and working through. I am a firm believer in randomized trials, but the points that you raised are valid ones. What I'd like to do is stay within the strengths of the randomized trial and try to figure out how to get around the problems, which are, by the time the trials is over, the technology has changed, or the drug has changed, or the situation has changed, or we haven't gotten it well matched to what we want. I still believe that if we could work, and what I'd love to do, is work on how to try to make the trials adapted to best fill our needs, not to walk away from something that I still think, when push comes to shove, is giving me the closest shot to having a true idea of the relationship between the intervention or the drug and the outcome.
Thank you, Julie. That was wonderful. And we'll all have the opportunity to speak with her at greater length. Join her in the NIH library in the next hall over for continued discussions and refreshments. Thank you.